This is Mark Dannenbaum from the Department of Neurosurgery at Emory University. We present the case of a 70-year-old female with intractable left-sided pulsatile tinnitus for 6 years found to be secondary to a Borden type 1 transverse sigmoid dural arteriovenous fistula. We normally reserve treatment for Borden type 2 or type 3 dural arteriovenous fistula. However, because of the chronic and intractable nature of her symptoms, we elected to pursue treatment. Access to the vascular system is gained in the usual way by single-wall puncture of the right femoral artery. A 6 French sheath is then introduced into the right femoral artery. 5,000 units of heparin are administered intravenously following sheath placement. Additional boluses of heparin are then administered at 1-hour intervals, and an ACT is checked to ensure that it is between 250 and 300. Using fluoroscopic guidance, selective catheterization is performed of the left common carotid artery, and with the assistance of a road map, the left common carotid artery is selectively catheterized with a 5 French vertebral catheter and a 0.035-inch Terumo glide wire. Digital subtraction angiography is performed centered over the head and neck, paying particular attention to the number and pattern of arterial feeders, in this case the middle meningeal and occipital arteries, as well as the patency and direction of flow of the transverse and sigmoid sinuses. The power injector is then configured in order to perform a 3-dimensional rotational angiogram with a longer delay to capture the nidus to better visualize the angioarchitecture of the fistula. The guide catheter is then prepared on the back table and connected to a rotating hemostatic valve. The system is connected to a flush and purged of all air in preparation for a guide catheter exchange. Using the existing road map, an exchange-link 35 Terumo glide wire is then buried in the external carotid system, the 5 French vertebral catheter is removed, and a 6 French penumbra neuron guide catheter is advanced over the exchange wire using fluoroscopic guidance and situated in the left external carotid artery. It is important to maintain a clean back table working environment in preparation for microcatheter placement and embolization. An Echelon 10 microcatheter and Synchro standard micro guide wire combination is assembled. This microcatheter was selected because of its onyx compatibility. The micro guide wire is then shaped with a blunt tip needle to facilitate optimal microcatheter and micro guide wire navigation in the external carotid system. A control angiogram is then performed through the guide catheter. Vascular access is then obtained in the left common femoral vein utilizing a micropuncture kit with gentle aspiration applied to a 10 cc syringe. A 6 French short sheath is then introduced into the vein over a 0.038-inch Benson guide wire. A 5 French vertebral catheter is then navigated through the inferior vena cava, right atrium, superior vena cava, left brachiocephalic vein, and left internal jugular vein. The anesthesiologist must be notified during this navigation while carefully monitoring for the development of arrhythmia. In tortuous patients, the use of a delayed road map through the arterial side is often quite helpful to delineate the course of the internal jugular vein, sigmoid sinus, and transverse sinus. Once the course of the internal jugular vein is clearly demonstrated, the 5 French diagnostic catheter is easily advanced over a 0.035-inch Terumo glide wire and situated in the left transverse sinus. A 6 French penumbra neuron guide catheter is then exchanged over a 0.035-inch Terumo glide wire and situated in the left sigmoid sinus. The microcatheter and microguide wire are then advanced into a parallel pouch adjacent to the transverse sigmoid junction. When a parallel pouch is present, patience and persistence are required to cannulate it. However, if successful, access to the parallel pouch is achieved and transvenous coil embolization of the fistula can be performed while preserving the patency of a sinus with antegrade functional venous outflow. Once the parallel pouch is successfully cannulated, the microguide wire is then withdrawn and a superselective venogram is then performed to verify location at the base of the fistula. We then review our coil inventory to select the appropriate size and shape of framing and filling coils, in particular gel and fibered coils. The coil is then inspected in saline on the back table, loaded in the RHV, and advanced under fluoroscopic guidance as demonstrated. Great care must be taken to maintain the coil mass and microcatheter access in the parallel pouch and avoid prolapse of coil and/or loss of microcatheter access into the lumen of the sinus. Coils are advanced in the standard fashion under fluoroscopic guidance until the detachment marker has crossed the proximal marker band on the microcatheter. This process is frequently referred to as teeing. An interval control angiogram is then performed that demonstrates persistence of the fistula as well as patency of antegrade flow in the transverse and sigmoid sinuses. After transvenous coil embolization, the shunt has been slowed down, however the fistula remains. Next, attention is returned to the arterial side. The echelon 10 and synchro standard microguide wire are then coaxially advanced through the penumbra neuron guide catheter. The left middle meningeal artery is then selected using roadmap guidance, and the microcatheter is advanced until it is wedged distally at the side of the fistula. At this point, proper microcatheter position is then confirmed using a superselective arteriogram. It is important to make note on the superselective arteriogram of the exact morphology of the target arterial pedicle as well as the recipient venous structures where the onyx will be deposited. Onyx should be shaken for at least 30 minutes prior to its use. The viscosity of onyx selected is variable. In general, larger feeders with fast flow utilize onyx 34, whereas onyx 18 is utilized in fistulae with smaller feeders and with slower shunting. DMSO is then drawn up and purged of air. The DMSO is then slowly injected into the microcatheter over 90 seconds to fill the dead space of the microcatheter. Care must be exercised to avoid rapidly injecting more volume than is required to fill the dead space of the microcatheter to prevent angionecrosis associated with the DMSO. It is not demonstrated in the video. However, one must utilize meticulous technique when connecting the 1 cc syringe of onyx to the hub of the microcatheter filled with the DMSO. It is important to have a fluid-fluid interface devoid of bubble. The standard technique involves directing the hub of the microcatheter downward while orienting the 1 cc syringe of onyx upward. The onyx is then slowly injected through the microcatheter that is wedged at the site of the fistula until the fistula is obliterated. It is important during the injection process to repeatedly acquire blank roadmaps in order to subtract out the previously injected embolic material and enhance visualization of the newly injected material. If onyx refluxes along the microcatheter, passes into the proximal part of the vein, or refluxes into other arterial feeders, the injection is paused for approximately 15 to 90 seconds prior to resuming. A small amount of reflux back along the catheter tip is actually necessary for delayed penetration of the nidus, and is usually not problematic because of the non-adhesive nature of the product. However, it is prudent to avoid more than 1 to 2 cm of reflux because onyx may still adhere a microcatheter into the vessel. In general, a greater degree of reflux in the external carotid system is tolerated than in the ICA or vertebral systems. Likewise, it is important not to pause the injection for greater than 2 minutes, as onyx may solidify and clog the microcatheter. If any unusual degree of resistance is encountered, the injection should be discontinued as a clogged microcatheter may burst with continued pressure. Finally, a control angiogram is performed to verify the complete obliteration of the fistula.